So in this table, there are totally nine diseases. First, we have the post-infectious glomerulonephritis, which is a nephritic syndrome, and this is immune complex mediated with a circulating or planted antigen. In this, we have the diffuse endocapillary proliferation, leukocytic infiltration, and there is granular IgG and C3 in the glomerular basal membrane and mesangium, and there are granular IgA deposits in some cases. So primarily it is a subepithelial hump. Subendothelial can be there in the early disease. So predominantly always you have to see the subepithelial. This is the post-infectious. The second is the good pasture syndrome. Good pasture syndrome causes RPGM. It is anti-glomerular basal membrane call for A3 antigen. And in this, we have the extracapillary proliferation with crescents and necrosis. There is linear IgG and C3 fibrin in the crescents. And there are no deposits in the good pastures. And there is the GBM disruptions and fibrin deposition in the electron microscopy. Coming to the third is the chronic glomerulonephritis, which presents as chronic renal failure. There is a variable pathogenesis. In this, we have the hyalinized glomeruli, the granular or negative fluorescence. Then coming to the next is the membranous nephropathy causes nephrotic syndrome. In this, we have the in situ immune complex formation, and we have the PLA2R antigen. In most cases, is the primary disease, mostly unknown. In this, we have the diffuse capillary wall thickening, and you have the granular immunoglobulin and secrete, which is the diffuse. And there are subepithelial deposits. The next one is the minimal change disease, which causes nephrotic syndrome. It's an unknown cause. There is a loss of glomerular polyanion podocyte injury. There is normal electron microscopy with lipid in the tubules, negative immunofluorescence, and loss of food processes with no deposits. The next one is the focal segmental glomerulosclerosis. This is causes nephrotic syndrome and non-nephrotic proteinuria. Unknown cause, ablation nephropathy, plasma factor, or podocyte injury. In this, we have focal and segmental sclerosis and halitosis. We have focal immunofluorescence of IgM and C3 in many cases, and electron microscopy, loss of food processes, and epithelial denudation. Then the next is the NTGN type 1, which is a nephrotic syndrome. In this, you have the immune complexes, and then this is the mesangial proliferative or the membranous proliferative pattern of proliferation. There is GBM thickening and important splitting. You have IgG, C3, C1q, C4, which is subendothelial. So tram track is under the sun. Then you have the dense deposit disease, which is a type 2 MPGN, which causes hematuria and chronic renal failure. There is autoantibody and an alternative complement pathway. Then in this, we have the mesangial proliferative or the membranous proliferative pattern of proliferation, GBM thickening and splitting. This is a C3 nephropathy. There is no C1q or C4, and there are dense deposits, electron microscopy. The last one is the IgA nephropathy, which causes the recurrent hematuria or proteinuria. Unknown cause, there is focal mesangial proliferative glomerulonephritis, mesangial widening, and IgA with or without IgG, IgM, and C3 in the mesangium, and it's a mesangial and a paramesangial dense deposit disease.